birth ratios. We can do that, Deputy Kelleher. The evidence is there internationally and so on, and I think part of the transition would have to be to standardise and normalise. But that also requires everyone to clearly understand it's a team game. So the consultants do a role, NCHDs do a role, nurses, midwives, healthcare assistants have a role, allied health professionals, all in a standardised structural approach based by best evidence. The best countries for outpatient outcomes are the ones that have patient ratios. California, New South Wales, Victoria, they have the best patient outcomes, but that's a significant investment and so on. Demographics, the cost and the fair deal. I don't think anyone, and that includes all of us, understands the edge of the precipice that we're standing on about the elder care and the demands that's going to be placed. It's not a question of them getting older, just, but their comorbidities are going to increase, and their expectation of treatment is going to increase, and that is going to only come the way of the health service. And we've got to respect, we pay respect. The pension situation in this country is such. How many of those will have, even if we left it as it is, will be able to afford private health care? They will all come through the public door. So the public door has got to be widened and prepared for that. And as I said, we've put in 2030 because we don't think this can be done in a year or 2 years. But equally, it can't be limited by the electoral cycle or the political thing. And as for the health capacity, where do you start? Yes, Deputy Kelleher. There is, if I just read present the committee with a short start. This is just one thing.
Keep it very tight. Yeah. There's a lot of people looking to come in.
In September 06, there were 3,724 people admitted for hospital care for whom there was no bed. In September 06. In September 2016, that number had risen to 7,551. That requires immediate attention. That's not 50 beds for every acute hospital in the country. That is a targeted, immediate capital investment programme in the 9 most problematic, most challenged hospitals. And that has got to be an immediate measure, not just because we say it or is politically expedient, but because patients need it. Okay. Thank you.
Okay, thank you. Deputy Buckley.
Thank you, Chair. I suppose, first of all, thank you for the presentation this morning. More importantly, thank you very much for your honesty and your frankness. The one thing I'm a bit confused about, I think you were reading all my questions. I don't know how you saw them, because you've hit on a lot of stuff. I'll just make a few brief points. Obviously, the morale within the system is at an all-time low. You've hit on, I suppose, the competence model of if a nurse has the competence to write a prescription, it should speed things up, so you've that covered. What I suppose that I would class at the moment is, it's a red flag issue, is I suppose the admissions of the elderly that have increased by over 5%. That's going to continue. Should we be looking at this within government, not only in this committee at the moment, to make this a massive issue of importance? Because if we're going to start clogging up hospitals, this is going to be a knock-on effect, and it's going to push our patients behind. The other one that you talked about was the mental health, the issues with school teachers and stuff. How would you address that? Would there be contractual stuff or issues with that? I see it on the point of nipping stuff at the bud. I can understand that. You hit on the existing contracts, so the big bang theory is kind of squeezed into a small bang theory. The accountability, leadership and confidence. If any of you were to do just one thing today that we could actually implement tomorrow, what would it be?
Okay. Grant. Thanks very much, Deputy Kelly.
Thanks, Chair, and thanks very much for your presentations. It's the first time I'll ever say this, but I don't think there was anything I disagreed with. And I do a lot of committee work, so it's the first time ever. But some thoughts, questions. We've 2 health committees in this Dáil, or in this Oireachtas. There's the normal health committee chaired by Dr. Hartley, and there's this health committee. This is kind of under the chairmanship of Deputy Shortall. This is kind of a once in a generation, once in possibly a lifetime opportunity to finally sort out the health service. And ultimately it is an ideological debate. Like the report that we're going to come out with, we have a timeline. The report that we're going to come out with is going to be pretty high level. Okay? It'll probably have some sort of indications as regards a plan, and I'll get into that, but it's going to be pretty high level. and hopefully not speaking out of turn, but I think most of us will come to a certain consensus as regards what we're going to decide in relation to a single-tier system, where services are free at the point of delivery. But we are going to have to absolutely deal with the questions and the challenges and the pressures that are come in relation to how we're going to fund that and the consequences of saying what you've just said in relation to, for instance, private health insurance. And that is something that we are going to have to bring the public with us, I believe, and we're going to have to bring yourselves with us in relation to supporting, because ultimately, as I said in the Dáil last week, morally, if we're ever going to start out the health service, we can't have the continuation of what's happening, where an elderly woman can go into a private emergency department, or go into a public emergency department and be on a trolley for 2 or 3 days, and 100 yards down the road an executive can go into a private version of the same hospital on the one campus and be treated immediately. It's just not equitable. It's 2016. So in relation to how we do this, my colleague has spoken about the Big Bang approach, and I agree with Liam. I don't think we can do a Big Bang approach. But we are going to have to, over the next, we've a mandate for 10 years, but let's not get too stuck on that. We are going to have to phase in the changes in relation to this ideological thought and how we're going to turn that around, how we're going to phase out the contracts that you've spoken about, how we're going to ensure that there's adequate funding, how we're going to prioritise the various different areas, like we've an absolute avalanche coming in relation to elderly care, complete avalanche. I can see it myself. So my first question is, given that sort of soliloquy which I've just stated, how would you, in relation to the process which we're going to go through and having a report on the future of healthcare and over the next 10 or so, 15 years, stopping that ship and turning it around and facing it out and putting it in the right direction, what are the areas and in what order would you see that we should prioritise across the health service, given that, say, we have written a report that hopefully there will be political support for on the basis of what I just said. So in other words, what areas and which do we prioritise, in what order and in what timeline? And it's a very difficult question, but I'd appreciate it. Second issue is, presuming that and it is to most of us, I would say, primary care and turning around primary care is an absolute priority, given the costs associated, just from pure financial sense, the costs associated with treating people in acute care versus in, for instance, elderly care versus in treating people in their home, etc. In relation to primary care, I mean, how quickly have we the capacity, working with your unions, working with your members, to actually turn that around, create a consistent primary care service across the country that's consistent throughout all its services? In what time frame? We know what we want, but in what time frame can we actually turn that around if it was a priority? And two last quick questions. One, we talked about restructuring fatigue. 7 hospital groups, 9 community health organisations, etc., etc. To me, it doesn't make sense, to be honest with you. I had a discussion in Clonmel with one of the authors recently. I told him it didn't make sense to me. There is restructuring fatigue. How can we bite through this? It's not just about us delivering a report saying that we need this structure, because, being honest with you, I'm not sure anyone will believe that. So how can we change the discourse on that in another way, so that to bring people with us, that there will be, of course, organisational change, but it's not going to be just a top-down approach. And finally, which is something that I would ask for a very quick answer on, is in relation to your members. We had a presentation a number of weeks ago on the use of technology, facilitating members, or facilitating your members as regards their work. How bad is it? Because obviously, from what I see, it's pretty bad. And in relation to facilitating the work that your members have to do on the ground. We all know the issues in relation to staffing. We all know that this is a huge issue. But also we all know that your members are not being facilitated through archaic systems which are in place. Thank you.
Thanks very much. Deputy Dr. Harty.
Thank you very much, and thank you very much for coming in. As you know, the purpose of this committee is to devise a single-tier health service which is based on need rather than on the ability to pay. So just two areas I'd like to cover. One is privatisation and one is work practices. So you referred earlier to frail elderly patients being big consumers of the health budget with multiple chronic conditions. And in our nursing home system, where we have a large number of frail elderly patients, those nursing homes are not really resourced to look after elderly patients who develop a deterioration in their illness. Consequently, they end up on casualty. In the same way, our community services are poorly resourced in relation to home care packages and home care services, resulting again in frail elderly ending up unnecessarily in our casualty departments. So is privatisation of elderly care, both residential and community, really going in the wrong direction? Because that's the way we are going, we're privatising it. Does that need to be reversed? The second question, in relation to work practices, are there demarcation barriers within the unions in the health service which are inhibiting change? And is there room for reform in this regard for more flexibility? Thank you.
Thank you for your brevity as well.
Maybe one or two, my other colleague to deal with the earlier questions.
Sure.
Please. Chairman, I'll be brief. Thank you very much. Firstly, in relation to the private sector involvement, I just want to touch on this. Unfortunately, Deputy Keller has had to excuse himself. It's not an ideological position. A lot of what's happening in relation to privatisation is reactionary. It's reactionary because we couldn't recruit people in the various skill sets. It's reactionary because there was a headcount moratorium. And, for instance, the issue concerning agency staff, that's reactionary. Over €330 million this year will be spent by the HSE on agency staff, right across from nursing professionals, medical professionals, and indeed, we described them here this morning, our deputy said, non-medical personnel. So, that's the first thing we have to say. That's reactionary. It's not value for money. And Deputy O'Reilly did refer to it as the ambulance service as well. There's a degree of the private sector taking advantage of the chaos that the National Health Service has to respond to in order to provide services, while somebody else is keeping an eye on the books saying, well, we didn't have to recruit these people to provide that service. The Deputy Harty is saying about asking about demarcation and so forth. We have people in the community who want to do more. For instance, you refer to home care packages. We have people providing home help services, and sometimes that's described in the community as some kind of a cottage industry. It is not. We have personnel who are described as non-medical people providing very key services, supporting their professional colleagues. And our members want to be placed in a position where they can do more. The other area, of course, too, is healthcare assistance. Healthcare assistant groups, the multitask attendant groups, again, want to do more, want to be allowed to do more, want to develop their role in support of their nursing professionals, and in support of their doctors and other allied health professional groups. They are the key issues that we think we can address. I think Deputy Buckley said, what one thing would you say can we do now? Well, first of all, there is a massive issue, and every one of us in this chamber understands today, about the care of the elderly. And it's as if we're drifting from crisis to crisis in relation to that. Obviously, value for money for the taxpayer doesn't mean that the services are surrendered to other groups who are saying that they can provide services, and then they can't actually provide them. There has to be a clear understanding that the public health service must be the lead care provider. And then after that, if there's ancillary work or additional work, that can be discussed about where that fits in. Because at the moment, it's continually reactionary. So we need to stop this reactionary issue in relation to deployment of staff, recruitment of staff, retention of staff. That can be done. The bill, €330 million on agency staff, that can be stopped. For instance, by immediately adopting a plan to invest in the training of not just professional staff, but also the group that you refer to as non-medical staff. At the moment, the HSE is paying for almost 900 home time equivalents in the healthcare assistant grade, which is coming in at around 60 to 65 million. That's not good value for money. That's not a good investment. The ambulance service, our members in recent times have had to threaten industrial action for the HSE and the Department of Health to invest in their service. In other words, to bring it up over an incremental period of time for the next 3 to 4 years, maybe 5 years, that it can actually respond to the growing needs of your communities, of our communities, and that needs investment. So the focus has to be investment in care of the elderly, investment in care in the community, and those services and those people who actually support it. And the General Secretary here in Congress, Patricia King, has made it quite clear. There's no silver bullet to this stuff. If it's a 10-year plan that's adopted by the Oireachtas members, well, then it's got to include the understanding that every cent that's available from the public purse has to be invested in a public health service that can deliver over that period. And short-term solutions are not going to work for us. And it's been proven with our neighbours in the United Kingdom. All those short-term reactionary responses to long-term issues actually end up failing and costing more money in relation to value for money, and also losing staff. Remember, the National Health Service in the United Kingdom is still short nursing professionals. They continue to come into this country trying to recruit nursing professionals and other medical professionals. Thank you.
Okay, thank you. Mr. Donnelly.
Yeah, I'll be very brief, but the questions have actually linked to a chain of answers. So I just want to start very briefly. I wanted to add one point on the questions Deputy Kelleher raised earlier, and in relation to what Naim said about nurse and patient ratios. And we agree with all that, but there's a populist view out there that our health service is bloated with managers and administrators and all of this. I'm reading from the census. So if we're talking about staffing levels, let's just not go to excuse me, an easy default position where we're bloated with managers. Our managers currently form 1.33% of the entire staff. 1.33%. It's in line with the NHS model, according to the Minister's own research. Our administrators in total, right down to the people who compile charts for doctors and consultants, are about 15%. So I just want to, if we're going to get into a debate about beefing up staffing, I would just make it clear to people that it's not just a simple question of we've too many managers and admin. But that leads to a chain of thought about managers, because Deputy Kelly said about the 9 CHO areas and the 7 hospital groups, which doesn't make sense to a lot of us. These managers have to go and manage this. So you talk about restructuring, fatigue, and that's exactly at the heart of it, because they're being asked to manage something that, quite frankly, a lot of people don't believe in. And they've got to go on a daily operational basis, try and introduce these things where there's a complete lack of buy-in from people because they don't know what's coming next, which leads into Deputy Hardy's question about demarcations. I'd say there probably are demarcations imposed by the system. And when Liam mentioned cross-referral, that's exactly what I'm talking about. Because if we could move to, whether it's in 9 CHOs or 9 community areas or 5 community or whatever it is, if we could move to community care where there was cross-referral between professionals who were highly qualified, occupational therapists, physiotherapists, public health nurses, that would remove a lot of the demarcations. But let me tell you this, and let me assure everybody, our people are up for that challenge. The difficulty is the lack of a vision that's presented to them and the lack of ability to manage that, because nobody is actually clear about what that vision is causing a slowdown in the system.
Okay.
Liam to address 2 or 3 of the other, finally 2 or 3 of the other key points.
Just if I could do it in reverse, thanks, Richard, about the frail elderly and the privatisation and the way back. Yes, Deputy Harty, we would have a very blunt view that what has happened in the last number of years with regard to the care of the older person services is doomed to failure. It's privatisation, the reliance upon private nursing homes, direct subvention to them, and so on. It will never, ever be able to meet the growing demands that are placed upon it. And the subtext of that is that the staffing levels in those nursing homes do not necessarily be the best, because you're managing, you're looking for profit and all those kind of things that come into it and so on. But the issue is as well, we have got to stop everybody being moved to the A&E the moment they have a temp or respirations up or whatever it is, right? And we've got to staff up those units so that they're capable of meeting those challenges, which are predictable challenges in many ways. They're very acute for the individual enduring them, but they're predictable to the health professionals who know the area. So that's why Congress is calling for a complete reversal in that area, so that you have a care of the older person service, whether it be in the home, whether it be in a long-term facility, whether it be in a transitional care facility or a rehab facility, all of which are directly subvented and properly staffed, so that you keep me out of the acute hospital if at all possible. And how we're going to manage the quantum. I think it's 1.7 million people over 65 by 2045 in this country. Think about it, 1.7, and there's only 650,000 now. So you have that huge stat coming up. So yes, privatisation of the elder person won't work in Ireland. It didn't work in other jurisdictions, and we have to come back up the road. Work practices, Eamon has touched on that. Look, there's no point in us coming in front of you saying everyone else has to change and we don't. Health professionals have to change. We have to have different models of care. We have to liberate each other. We have to complement each other. But, Deputy Harty, we don't and we can't survive on a medical model of care for our public health service. It's got to be one that is originated by the right person in the right place, empowered to do it. And that's why we're calling for regulation and independent inspection, so that you can cross-check all those things happening all of the time. No one has a divine right to work away from public scrutiny when you're talking about health. So that's why we put in regulation and inspection. What will we do now? What will be the one thing we do now? Paul touched on that. Colleagues, what we have to do now is staff our health service properly to meet the demands being placed upon it. And for example, you talk about public health. We train 100 public health nurses a year. The first 6 months of this year, there's 41 less public health nurses in the public health service than there were at the beginning of the year, because we can't replace. We need to massive investment training programme for 200 public health nurses a year at a minimum, and we have to staff up. Paul is right. Healthcare assistants, home help people, it's not all about high-level consultants or multi-qualified nurses and so on. It's about the whole team situation and all the rest. And you can't do that by paying, with respect, the minimum wage to people providing home care. Right? There's many areas in this country now where they can't provide home care, even though there's a bit of money, because they can't get the staff. So the end product is Mr. Murphy or Mrs. Murphy ends back sooner or later in the ED because a bit of support they couldn't get, because the minimum wage won't cut it. So the one thing you can do is invest in the one thing that every health service needs: motivated staff.
Okay.
And we're depleted at the moment.
Thank you. Deputy Barry.
Thank you, Chair. I have 3 questions. Before I put the questions, I'll just say that it's been interesting to listen to what you've had to say, and I do hear the points that are coming across strongly about elder care. But my questions, the first one is on the issue of morale. I'm picking up different threads from what's being said. Liam Doran, you've just mentioned the issue of low pay. One that's come across strongly is, I think it was yourself, Eamon, made the point, lack of a buy-in when people don't know what's coming next. Restructuring fatigue. And the question of staffing has been touched on. I'm just asking you if you could pull that together a little bit. The issue of morale comes up again and again, the health service among health service workers. Is that it? Staffing levels, pay, and where the hell are we going? What's the balance between them? Are there other factors? Could you just put the jigsaw together there a wee bit with your knowledge and expertise? The second point is there's a couple of very interesting quotes in the INMO document. It's a very interesting issue which hasn't come before this committee before. I'm just going to quote very quickly. Integrated care requires a simplified organisational structure which clearly indicates responsibility for service delivery. This can only be done by devolving responsibility for the provision of all care to the front line. And a fully integrated service within a flat management structure with responsibility, autonomy devolved to clinical frontline managers who can access all services for the patient client. The issue that's posed here is the issue of management and control in a day-to-day sense of the health service. Some of the points there remind me of stuff that you used to see in the 1970s about, workers' control of services and industry and so on and so forth. But leave the ideological side of it to one side. In a practical, pragmatic sense, can you give a little bit more of an idea, of a flavour of how you think devolving control and responsibility down to the grassroots in the health service and the front line in the health service would make it better? Can you give some examples of that? I'd be interested to hear a bit on that. And final point is that I hear the points that are being made about one-tier health service, about it not being based on ability to pay. Of course, a big question is how do you get from A to B? And I've listened to the points there about, where the taxpayers' money goes and where it doesn't go. And I think there's good points there. I'm presuming, but I want to clarify that that you would support the idea of a health service which effectively would be free at the point of use, something like the NHS in Britain. It's not fully spelled out; it's kind of strongly implicit in the document. But I'd like just to clarify that that's the position.
Grant, thanks very much, Deputy Brown.
Thank you, Chair. And, I welcome the presentations here today. Just a couple of quick questions. Firstly, in relation to kind of the agency work and privatisation in that sense, and just, for example, in home care help, a lot of that has been handed out to agency work. The HSE pay, I think, something like €34 per hour. The staff providing that very often are getting barely over minimum wage, and there seems to be completely serious inefficiency there, and the public are not getting bang for their buck when you're seeing that kind of money disappearing between what's being paid and then what workers are actually getting. And is that purely reactionary? Is there an ideology within the HSE to kind of drive on privacy work? And then also tied into that, the issue of monitoring. We're seeing increasing the drive towards decongregation. Someone mentioned, I think it was Patricia mentioned, we're 5 or 6 years behind what's happening, and I'm interested in reading what's coming out of the UK now in terms of mental health. In some cases, they've gone too far in terms of pushing people back out into the community, and now we're seeing situations here arising down places like Kerry and so forth where they're driving on, and just kind of the comments in terms of monitoring in community, because that monitoring, HICWA goes into institutions, the Mental Health Commission goes into institutions, but there seems to be very little monitoring of what's going on in the community. There's a lot of good people working in agency work, but they're also coming telling me that some of the people that are being hired and going into people's homes are simply not qualified. I'm just interested in your comments around that. In terms of getting any change that would be proposed out of here, there has to be trade union buy-in, and then there has to be staff buy-in. But sometimes even when that happens, I think management kind of, or I suppose a higher up management forget that, think that's their job done. In terms of bringing then the staff along through change management, through change implementation, how do you now get staff to, I suppose, when they're fatigued, and I know the managers are fatigued as well in terms of report fatigue, how do you get the staff to now once again, I suppose, take another leap of faith and go along again? And just kind of comments in terms of collaboration. And I know other countries have very strong collaboration between staff and management, and just the comments around that. In relation to, I suppose, what we don't want to come out of here is another report to gather dust. So do you believe that what comes out of here should be underpinned with legislation? We're heading towards, I suppose, another continued period of somewhat instability in terms of future governments, more coalitions, that if this is going to take 10 or 15 years, we not only need a clear plan, but to know that that plan will be implemented. Do you support this report being implemented as or underpinned by legislation? I suppose you probably want to see what the report is going to say firstly, but your comments on that. And then just finally, on a governance ethical model, your comments around, I suppose, staff and management. Should there be an annual assessment of staff and management in terms of their capability or their ability to continue doing their job, or in terms of their professional development, as opposed to the current system where kind of whether it's staff or whether it's management, you're kind of only assessed for your competence once something kind of goes wrong? And just your comments around that.
All right. Thank you, Deputy. I just say to everybody now, we're actually 10 minutes over time and there's other groups outside waiting to come in. So please keep it as brief as possible. Deputy Brazel.
Thank you. I will be very brief. Just one query really regarding, I've spoken to hospital managers. They're paying way over the top for agency staff and they're not allowed to recruit. I just don't really understand that. Like, what am I missing if it's costing 3 times the cost to the HSE for agency than it would be to recruit somebody? Just, you might shed some light on that for me, please. And the second question, I was just reading through the documentation last night, and it's something that I'm trying to grapple with myself since the start of the process. The structure around the 7 hospital groups and the 9 community health organisations. Is that a working structure? Because in your own documentation, like Congress, one line I highlighted, Congress broadly welcomes the recent establishment of the 7 hospital groups, and goes on to say that it's something that could work. And then in some of the individual presentations, and I think, Eamon, in your own few words, you expressed reservations. So I'm just wondering, do we have to look at something? I don't think maybe, again, there's any ideal scenario, but do we set something up and just go with it and modify it as we go along to fix it as we go along, because you're never going to set something up right in the first place. It's just too difficult a task. I just again like your opinions on that. Thank you.
Thank you, yeah. And I'd just like to add to that final point, because it's something that we're grappling with here as a committee. We very much recognise the fact that there is change fatigue across the system, and yet at the same time, on a weekly basis, it comes up here. How do you have an integrated system when you have 7 hospital groups and 9 CHOs, and they're not aligned? So, I mean, maybe, well, I know there isn't time to discuss that here. I don't know to what extent Congress has considered the organisational structures. I know, Liam, yourself, you said there in your introductory statements that we needed a simplified, integrated and readily understood organisational structure. We certainly don't have that at the moment. So have you given much thought to organisational administrative structures? And if not, maybe you'd come back to us on that point, because it's something that's coming up time and time again. And we're very slow to consider recommending yet another change, but at the same time, we can't get our heads around the fact, how you could possibly have an integrated system with that disintegration that's there between acute hospitals and community.
Okay. Well, if you start from the back, okay, we only are 4.75 million people for a start in terms of health service, okay? The reason why Congress welcomes the hospital groups in the context of what went there before is that you have some level of cohesion and reduction in duplication. Prior to that, we had a number of years where you had hospitals, all competing for lung and liver transplants and all these kind of things and so on. So the hospital groups is a step in terms of coordination. But we will come back certainly. But let's be quite clear. There is no rhyme or reason to 7 hospital groups, 9 CHOs, 7 mental health areas, and numerous Section 39 facilities, all doing excellent work in their own way. We're not knocking the work, but the management of that, as Eamon says, leaves it impossible for people. And then on top of all of that, you have a centralised HSE. So if I could just link that back to what about, it's about devolving power. How do you run a health service where the local manager of a hospital is not empowered to fill posts that fall vacant within their stated staffing complement. They have to go up through 3 rungs of a ladder to live within a pay and budget control, up to 100 miles away to people they never see, and make a business case. If I hear the phrase business case anymore, running a health service, and I'm the manager of the local hospital or the local health service, and I have to make a business case to fill a post that was there that just fall vacant because somebody's retired or left or emigrated, and I have to wait 6 months to get it, and so on. And that's why they fall onto the agency spend, Deputy Brazel, because what happens then is that they can't do it through the permanent, if you like, pay structure, but yet they determine, as the lead clinician, that they have to have that staff member, because otherwise patient care is compromised. So the easy opt-out clause is, I'll go to King and Doran Agency Limited and get the staff in. I could be in for months while they're waiting for the business case at a cost of 5% on the shift premium and 21% VAT on the health service. But that's how you end up with an explosion. And the other reason you end up with an explosion is because the pay and conditions are not attractive, and this is particularly with respect to the our medical colleagues at the moment, they can choose to work via the agency model and so on, knowing that the hospital has to take them because they have no other way of filling the senior clinical decision-making gap. And that's the medical agency spend has increased significantly in recent years because, in fairness to our medical union colleagues, they would say, yeah, the paying conditions aren't competitive and so on. So the whole funding model, when we talk about devolving, Deputy Barron, we talk about devolving, it is those people who are responsible for the care. So they've got to be empowered to maintain a staffing profile and be accountable for that expenditure. Everyone has to be accountable when you're spending taxpayers' money. But you can't, but at the moment you have to be accountable, but you have no autonomy to do the thing right. But you're still accountable for the misadventures. In terms of single-tiered, free. Yes, I think we are free at the points of use for a health service. Let's be quite clear. It's free at the point, and no hidden charges in terms of creeping in and so on. Agency care, mental health and ID, congregated settings. Yes, I think you are right. I think it's become extremely, and we think extremely fashionable to talk about decongregated settings and forgetting totally about the needs of that person, whether they have an intellectual disability or a mental disability, to survive in that more normal community setting. Maybe they'll blossom and be more productive and more involved in the community if they have more protected environment. It isn't that you go from all residential to all community. There is that blend in the middle, and the current Kerry thing is an example of that. And no one knows better than the relatives of the person as to how the person blossoms. And when the system dictates to the family what it thinks is right and the family's view is disregarded, we haven't got a public health service. So, I mean, that's there. And then the final thing about the hospital groups and so on, I think, rights, the only thing I'd say, and I'll observe my colleagues, about what happens to the report, I think we would certainly have a view that you have a right to a public health service. You have a right to a public. When you leave it to discretion, and that's not enshrined, if you like, then, you know, we had this with disability services. No one wanted to pass legislation which gave me the right to a service. You have the right to seek access to. So a public health service, free at the point of use, universal, single-tiered, yes, if that can be brought forward and underpinned by legislation, I genuinely think you're serving the community and the economy.
So, Chair, just from we take up the invitation to maybe on some of the supplementary pieces that were raised in the questions that we didn't get an opportunity to answer, that we would maybe offer our view in relation to some of those. And just finally to say that the reason we welcome the opportunity to present and the fact that the committee in the first place has been set up because and some of the issues were raised by various deputies, Deputy Kelly, Deputy Barry and so on in the most recent questions. If policymakers can actually grapple with and identify some of the big ticket issues, like, for instance, the funding model and so on, and how the system works with fluidity. If that can be grappled with, then I think that you start on the road to building the morale of people working on the ground, because they will then see that actually the big ticket issues that they know are unworkable and that are really causing all of the dysfunctionality in the system, if they see the big ticket issues being actually, from a policy point of view, being taken on board and somebody, a group of policymakers trying to tackle them, that I think will be a game changer in terms of, or could be a game changer in terms of how those who deliver the service at all levels react to it.
Right. Thank you.
Respond to the question the Deputy did ask.
Just very briefly.
Absolutely,
Paul,
Chair. Thank you very much, Chair.
Yeah.
You raised the question, Deputy, about standards in care in the community. In other words, what we would traditionally refer to as home helps and the standard of care they provide. The only way of underpinning that and addressing that issue for groups that you refer to as non-medical is actually the industry itself has to be regulated, or the service, sorry, has to be regulated. But those who provide that have to be introduced to a system of registration where there's obligations they have to meet, and that would include healthcare assistant groups as well, because that means that in order to provide that service, be it in a community or an institutional setting, you must have a certain level of qualification and an obligation by the service provider or the individual to continually improve and train and educate to meet that standard, and that needs to be addressed. Thank you, Jim.
Thank you very much. Just with that, I'd like to thank you all for coming in, for being so generous with your time, and for your submissions today and your original submissions as well. We'd very much appreciate you, Congress, just giving some more thought to organisational structures. As I say, it's a big issue that we're grappling with at the moment, and we'd welcome your input into that. Thank you very much. Thank you. Just suspending the meeting now for 5 minutes, and I'd ask people to be back in 5 minutes for our next group. We will now resume in public session. Is that agreed? Thank you. So for the committee's second session this morning, we're discussing health service reform and the concerns of a number of organisations presenting to us here this morning. It's now the turn of the Irish Medical Organisation to present to the committee, and I would like to very warmly welcome our guest, Dr. Peadar Gilligan, Chair of the Irish Medical Organisation's Consultant Committee, Dr. Padraig McGarry, Chair of the IMO's General Practice Committee, and Mr. Cian O'Dowd, Policy and International Affairs Officer of the IMO. You're very welcome. And apologies again for the delay in getting started. Just some formalities first of all. I wish to advise the witnesses that by virtue of section 17(2)(1 of the Defamation Act of 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. If you're directed by the committee to cease giving evidence in relation to a particular matter and you continue to so do, you're entitled thereafter only to a qualified privilege in respect of your evidence. You're directed that only evidence connected with the subject matter of these proceedings is to be given, and you're asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any person, persons or entity by name or in such a way as to make him, her or it identifiable. And finally, members then are reminded of the long-standing ruling of the Chair to the effect that members should not comment on, criticise or make charges against a person outside the House or an official by name in such a way as to make him or her identifiable. I'd now like to invite Dr. Gilligan to make the first part of the opening statement. Thank you.
Thank you. Madam Chairman, members of the committee, ladies and gentlemen, good morning. Thank you for affording this opportunity to the Irish Medical Organisation to set out the views of doctors in Ireland on the future of Irish healthcare. As you are aware, the Irish Medical Organisation is both the representative body and trade union for the medical profession in this country, representing all categories of doctors, including non-consultant hospital doctors, community health doctors, public health doctors, general practitioners and consultants. The experiences of the medical profession in Ireland have informed our submission to this committee, and the development of a caring and effective health service is core to the IMO's mission. The written submission made by our organisation to this committee provides recommendations on a wide range of health service activities. However, this morning I would like to focus the opening statement that Dr. McGarry and I are making on central aspects of the future of Irish healthcare. 1. Capacity. 2. Staffing. And 3. The role of general practice. These are system-wide issues that, unless appropriately resolved, will inhibit the development in other areas of the health service. The media coverage of Irish healthcare frequently centres on hospital care and, in particular, emergency department overcrowding. As an emergency medicine consultant, I have been witness to the very real impact on patient care that cuts in health service funding have had. Our ability to provide high-quality care to patients in a timely manner is truly compromised in Ireland, as manifested by admitted patients spending in excess of 12 hours in emergency departments following a decision that admission is necessary, and the increasing waiting lists for planned care delivery. One of the most significant reductions made within the health service was to bed capacity, and the effect of this is evident in every acute hospital in the country on a daily basis. There are about 12,800 acute beds within the hospital system, 800 fewer than in 2007. Of these, 10,800 are inpatient beds, 1,300 fewer than in 2007. Contrast those 10,800 inpatient beds with the 14,700 inpatient beds the Department of Health said back in 2003 that we would need by 2011, or the approximately 14,600 inpatient beds we would have if we adopted the West European average. To put it bluntly, acute beds currently available within the acute hospital system are too few to provide care to patients in a safe manner, and unless urgent steps are taken to remedy this shortfall, many will continue to experience significant delays and preventable deaths will continue to happen. We have heard repeated promises of a bed capacity review, but no action appears to have been taken. Such a review is needed to determine precisely how many and what type of beds should be placed within the acute hospital system to provide adequate capacity on a medium to long-term basis. However, in the short term, inpatient beds must be restored to the system at a faster rate than is currently occurring. Deficits of medical staffing restrict patient access to care and the quality of that care. The 2003 report by the National Task Force on Medical Staffing, when applied to our current population, sets out a requirement for 4,400 consultants in the health service. Today, however, there are just over 2,700, and as a result, we have long waiting lists for outpatients and procedures across virtually all medical specialties. Comprehensive manpower planning must be undertaken to develop a consultant-delivered health service. At present, however, we are being forced to cope with a grossly understaffed hospital system where the patient experience of care is not as their doctors would wish. Both consultants and non-consultant hospital doctors, the next generation of consultants, are being pressed into excessive levels of service provision which jeopardise patient care through the generation of unacceptable clinical workloads. It is little wonder that few doctors see working in Ireland as an attractive choice or one compatible with their professional development. Accordingly, we have one of the lowest numbers of practising doctors per capita in the EU at just 2.8 per thousand of population, compared to an EU average of 3.4. As a direct result of a failure to honour consultant and trainee contracts, public sector cuts and the further catastrophic 30% reduction in salary to all new consultants imposed in 2012, there are in excess of 250 unfilled consultant posts in Ireland, with 1/4 of advertised consultant posts receiving no applicants. This does not augur well for the future of hospital care in Ireland. Irish-trained doctors continue to leave the country in significant numbers. Figures gathered by the OECD reveal that Ireland has the highest reliance on foreign-trained doctors of any country in the EU. Our own research has found that just 40% of Ireland's medical graduates plan to practice in Ireland, while studies by the Medical Council demonstrate that health service understaffing in Ireland is the leading reason why our doctors are leaving to practice abroad. Unless the issues of adequate acute hospital capacity and medical staffing are satisfactorily resolved, we will struggle to fill medical posts in our health service. Inadequate resourcing of hospitals in Ireland has compromised patient care, and as a result, patients and the